I think we would like to proceed with our second lecture regarding the dual antiplatelet therapy in TIA. What's the evidence? So before we start, I would like to introduce Dr. Wan Asyraf. He's our stroke neurologist, stroke doctor. Okay, he's we know that he's a stroke he's also clinical lecturer from the hospital Universiti Kebangsaan Malaysia lah. Sekarang dah nama jadi Hospital Canselor Tunku Mukhriz. So he get his medical doctor training from UKM in 2009 and also graduated for his postgraduate from from UKM also in 2016, and he obtained his neurology fellowship in 2019. His research interest is acute stroke, reperfusion treatment, stroke rehabilitation, and stroke prevention. I think without any further ado, I would like to invite Dr. Wan Asyraf to deliver his lecture. Thank you, Dr.
Thank you, Dr. Hafiza. Thank you, team NIHSS for the invitation. And I'll start my presentation. Okay, can you see my screen? Yeah, just bear with me. I try to share as much as possible because of the question I changed a bit. DAPT or DAPT in stroke or TIA just now is also a stroke. Why I choose? Okay, can you listen to me? Sorry.
Yes.
Yes. Okay. So why I choose from TIA to stroke is basically I usually don't like to put transient ischemic attack, and then people don't entertain TIA as a stroke. So basically, transient ischemic attack is also a stroke, and there is evidence. So that's why we want to discuss the evidence. And as mentioned, so I claim myself as a stroke neurologist. I do research in stroke. I'm practicing in stroke, and also I'm teaching stroke and Faculty of Medicine UKM. Okay, so my next slide. Oops. Okay. While Harudin mentioned just now, so I just want to share disclosure a bit. There's no sponsor for this talk. I share my opinion and this is my own interpretation based on the current readings and materials of evidence that I have been exposed to and I have went through. Just now, I saw the phases of stroke. This is the recent phases of stroke that agreed by all stroke physicians and those that are doing research in stroke. So hyperacute stroke now, including service, not only research, so now it's already up to 24 hours. That's why UKM is one of the Malaysia first center to provide hyperacute assessment within 24 hours with all the all-out investigation upon arrival to the hospital. The only one, I think, at the moment, 24/7. But I think we have a few other colleagues try to set up because of it really require a bit of more human resource. And then following that will be acute stroke within the first 1 week. So we change it to acute stroke, early subacute stroke, late subacute stroke, then chronic. So this is what has been agreed in research, and obviously it's already translated to service nowadays. I think this is already quite some time. Okay, so it's not complete. Before we going to the evidence, we need to understand a few bit. Okay, I hope I will be within time. So cerebral ischemia that we are going to concentrate rather than ICH because of 80% of the strokes. Obviously, TIA is actually ischemic, transient ischemic attack, and stroke is because of reduction of blood flow or due to obstruction, due to thrombus, stenosis, meaning there's narrowing of the blood vessels, or because of there's a progressive narrowing of vasculitis or dissection. So, and this cause reduction, alteration of the cerebral, alteration of the cerebral function. So when we discuss about the ischemic area, there will be ischemic core, which is very much susceptible immediately. Usually in hyperacute, there is a clot, for example, there's a thrombus, not chronic stenosis. The core will be immediately the gray matter. Okay, so there's predilection to the gray matter. That's why you do MRI, the flare will be called first positive at the gray matter. And then, the DWI will be positive at the gray matter almost immediately. So be careful if you looking at hyperacute MRI. Okay, and penumbra is the area that is ischemic but not yet infarcted. So this is the area that if you salvage, then the patient can recover if the area is basically functional enough and not as eloquent as required for the particular patient. So transient ischemic attack, we know there's a blood flow issues, and symptom lasted less than 24 hours in majority of the journals. Then I will show to you later, there's a score called ABCD2 called square. So maybe that's one thing that you want to use, but that's limitation in terms of that. But anything that beyond 24 hours will be ischemic stroke. Yeah. So in a fast manner, stroke subtypes can be divided to these two. In our population, almost 80% is ischemic and another 20% is hemorrhagic. This is actually quite high number of hemorrhagic, and this commonly young. And cardioembolism is only about 25 to 30%. Large artery atherosclerotic disease is roughly about 30 to 40%. Small artery disease is lacuna. Just now, I heard about mentioning of lacuna. The joke about lacuna is if you really know the histology, can we really see from our own eye? Lacuna is basically most likely related to small vessels that must have lipohalinosis and is often related to hypertension. And then we have the cryptogenic stroke, which we don't know, but often here we want to discuss about ESUS, embolic stroke of unknown source. So there is a thrombus that coming emboli, but we don't know where it's coming from. It can be from the aortic arch thrombus. It can be from the carotid dissection or called a dissection. Then it's not cryptogenic anymore. It can be a small thing that you miss because of it's a thick slice CTA. There's a carotid web. So those are the things that we need to reduce in terms of the small error. Then finally, maybe we reduce our cryptogenic stroke. The other words for cryptogenic is I don't know. Okay. Unusual arthritis, usually this commonly happen in young stroke or dissection. So we look at the young stroke for this. And obviously, sometimes it happen in not young population, but that's rare. So I just go in particular because when we discuss about the optimization and in particular to choose antiplatelet to DAPT, the most benefit is actually with the large artery disease. The most benefit, I didn't mean that there's no benefit for the others because of this concurrent issues, for example, concurrent IHD, peripheral vascular disease, often related with a patient with a stroke. So stenosis is one way to cause a stroke in large artery disease. So as you can see over here, this patient basically had a stenosis over the left MCA, distal and the branching distal of the M1 is actually tortuous over there, then become bifurcate to become M2. So this area that then produced the lenticlostriate artery basically suffered, and there's a this one is not the perforator, sorry. This one is the area that because of the stenosis over here causing the MCA. Actually, if you go high up, I didn't take another slice, there's a multiple other stroke because of there is reduction of blood flow distal to the MCA. So that's one way. So this one, for example, so this is actually the same patient. So going higher up, you can see stroke in MCA. But this patient, after about 3 years after the right MCA stroke, now presented with aphasia at times when the patient is basically trying to walk fast or doing this power walk, yeah, and right-sided body weakness witnessed by the family member. So this patient, as you can see, the reason why I show perfusion is not to ask you to do perfusion for everyone. It's basically to look at how perfusion make our life is so much easy because of aphasia is left-sided. And this is the left carotid, which is actually stenosed at just one point over there, about 90%. And that's causing the perfusion of the distal flow issue. So that's why the stenosis causes distal flow issue of an ICA like this. So this is a symptomatic ICA occlusion extracranial. And this is what happened after we open up using carotid artery and atherectomy. So this is surgery. We remove that one. So while waiting for the surgery date, or in Malaysia is a bit different. There's a lot of family meetings. We need to basically counsel the family and the patient, finally agreeable because of the risk of stroke is high. There's a bit of stroke, and anyway, if you compare to the first scan, but it's a mild stroke that he recovered again, and this is after the surgery. Okay, so the perfusion improved. That's how easy you assess perfusion of the brain with CT perfusion. And the second mechanism in large artery disease, it can be a thrombus. So this is a 40-40 window. I usually do teaching now with only 2 windows, 80-40 window, 90-40 window, or 40-40 window, because of the others can cause more artifacts and you cannot appreciate what I wanted to show over here. So this is cytothrombosis at the right proximal M1. Okay, and this patient had this. Okay, so this is the thrombus. Okay, and this patient actually NIHSS was 1, the most, and symptom is already at about 17 hours fluctuation. Some will call capsular warning syndrome, but as you can see, this patient had good collaterals from this cut. And for us with CT perfusion, we just look at CBV and the CBF. We know that the collaterals is good. There's some increased CBV over here. However, the patient keep on having symptom with a thrombus. There's no filling of the CTA over here because of there's a thrombus occluding it. So this is a patient that arrived to us within 24 hours. If you're interested, we then treat as timeless, but using autoplay. So he received thrombolysis successfully. So that's in situ thrombosis. And the third and fourth mechanism to basically, cause of time limit. So I just go with perforators compromised because of lenticulated right artery or the perforators. Yeah, so we have called the perforators coming from the recurrent artery of Hübner, from the MCA, and also the PCA. So then it will cause the subcortical stroke. And if it were to be compromised like this, subcortical like this, so that's called the sublentiform area, and also at the internal capsule area. So there's maybe 2 perforators that suffered. This is a patient with a bit of thrombophilia condition due to nephrotic syndrome. So there's maybe in situ thrombosis of the small vessels, and the perforator compromised because of the flow. MCA was stenosed. So that's combination of the above. That's the number 4. Okay. So this is the scan just now. As you can see, I changed the CTA to the brain window. You can see nicely this area, and the CT perfusion will be positive. Then there's another paper. This is anatomy, what I mentioned just now. So that's another paper. If you look into CT perfusion and you have the maps to be positive, this is the thin size CT perfusion, then the likelihood is more than 50%. The stroke will progress anyway. And then I told you just now, diagnosis, prognosis will progress. But this is without a significant stenosis. Stenosis is about 30% only. It's not really more than 50%. More than 70% is severe. So this is likely due to the underlying prothrombotic condition. Okay. So I told you when we are talking about the TIA, we need to have a bit of these things. ABCD2 score published by Professor Clay Johnson in 2007 is about to predict the occurrence of stroke within the first 90 days. So the recurrence of stroke with certain clinical factors, for example, age, more than 60, blood pressure on arrival of more than 140/90, and clinical features, whether it's weakness, the score is higher, 2, speech disturbance alone is 1, which I don't really agree if the perfusion is like that. The first patient or second patient just now, and the duration of symptoms here, then you notice anything more than 10 minutes usually is a stroke actually. Obviously, the longer, then it become the more likely to be a stroke. And history of diabetes. So the higher ABCD2 score is associated with more stroke recurrence, and it can go as high as 20%. And as you can see over here, this is actually almost 10%, and this happened within the first 48 hours. So that's the reason why the topic today is relevant. Some of the other definition that you want to know is, and you need to know, is mild stroke, NIHSS less than 4, mild moderate stroke, NIHSS less than 6, and soon there will be another one that hopefully after that trial complete, then we know there's another moderate stroke level. So why we need to discuss about antiplatelet, because of not antiplatelet alone as part of the optimal medical therapy, but we know after ischemic stroke, there's increased platelet activity as part of the risk of another stroke. Not only just the vessels become more stenosed or maybe injured, not just the cytokines. It's basically there's the blood's constituent consists of platelet activity, and a stroke itself increase the platelet activity, especially when there's atheroma. As you can see, you go to the large artery stroke, the platelet called aggregation will be higher, and that's significant compared to control. So in summary, for the stroke, when there's a stroke happen, platelet is activated, it aggregates, it causes thrombus at the atheroma, and there's a prothrombotic state, and you know that it is higher incidence in the large artery disease, and obviously the two combination is not a good thing, and you need to optimize the antiplatelet. Okay, in one go for just antiplatelet, before we go to the DAPT, we must start with something like a single agent. For example, aspirin, here in the International Stroke Trial 1 in 1997, then the Chinese Acute Stroke Trial in 1997, the same year, they studied aspirin versus the unfractionated heparin, where the unfractionated heparin also reduced the risk of stroke, but aspirin seems to be called safer, less bleeding. So I'll show with the next table. Following that, clopidogrel, a Capri and match study, and heparin, I mentioned just now, IST1, warfarin in the warfarin recurrent stroke study, aspirin dipridamole, aspirin 2006, then later on in 2013, then Chance in China, they get to know that aspirin clopidogrel is actually better for stroke prevention. However, just to share with you, there's a study that I was involved in 2014, 2017. We noticed that we didn't adopt the DAPT yet until recently. I think it's after the point trial. So we are a bit more British. Okay, and then aspirin ticagrelor. So in summary, just for the single agent stroke prevention in terms of numbers, so you can see the stroke incidence is about the rate of stroke in terms of percentage. This one, if I'm not mistaken, this is for within 2 weeks from onset for International Stroke Trial 1. This is 2.8% and 3.9% comparing to placebo. So aspirin is better than not giving anything. So, but very, very small margins over there. Chinese acute stroke trial shows similar thing, but this is within 1 month. And Capri, they look into this one is, I think, the annual rate. So this is quite low, but they look at stroke, MI, and death. And as you can see, clopidogrel is actually better than aspirin. And then match clopidogrel versus clopidogrel combination, you see there's no much different. And the one in the bracket is basically bleeding incidence. That's why clopidogrel is being preferred when you then look into the high-risk group and the post-stroke patient at one moment, so as monotherapy. And warfarin also being studied in the WARS trial, and you can see that warfarin is actually, which is the target INR of 1.4 to 2.8 during that time, but the median was 2.1. The risk of stroke is actually a higher incidence compared to annual rate. This is 2-year rate, and this is quite high. So you can see from the what you can see from even the early study, the risk of stroke actually increasing after the first 90 days. And then we go to the dual agent stroke prevention, the aspirin dipridamole, which is not available as a combination in our country, and now I don't think so it's available anymore, which is more effective than aspirin alone. Then Chance trial, as mentioned, 2013, it was published, aspirin clopidogrel versus aspirin, obviously the combination is actually better in terms of stroke prevention. And recently, we have able to make sure ticagrelor is approved for 1 month at least in the KKM centers. Ticagrelor aspirin combination associated with less reduction of with less stroke incidence. Sorry, and aspirin is actually single agent. However, we know we also have the Asian bloods where the CYP2C19 non-functional allele presence. Then when there is a group of the CYP2C19 non-functional allele positive, then the patient should receive ticagrelor aspirin rather than clopidogrel aspirin. And just a bit here because of CSPS2, sorry, the S again. This is chilostazol stroke, secondary stroke prevention trial in Japan. Chilostazol with aspirin or clopidogrel combination associated with markedly low incidence of stroke as compared to aspirin or clopidogrel as monotherapy. So I do practice this. However, chilostazol is not highly tolerated in certain patients. There's almost as high as 60-70% adverse event, but not really bleeding. It's headache, tachycardia. Okay, so the thing with stroke, as you know about the antiplatelet just now, we need to intervene as fast as possible because of the risk of stroke within the first 24 hours significantly very steep. The rate is very, very high before it plateau, although the rate slowly increase. Yeah, so basically we need to start as fast as possible. There's few ongoing trials looking at stroke prevention within this subgroup, large artery disease, small volume of lacuna, that require as soon as possible to know the vessel status in majority of the trials. And some of the trials, because of acknowledging like country like us with no vascular imaging in majority part of the state, it's still become more inclusive, but we still need to know that we need to randomize or we need to treat the patient as soon as possible within the first 24 hours. We need to treat them as fast as possible. Okay, and just to remind you again, okay, because of this, the platelet aggregation, because of the immature platelet increasing in number, and this is as a response to the acute ischemic stroke. Okay, so I need to go beyond this. Okay, so actually I just want to go a bit because I told you just now the ticagrelor compared to the clopidogrel. If you can see over here, this is aspirin and this is clopidogrel. So these two are non-reversible called inhibitor of the platelet. So basically it just catch the mature platelet and then inhibit it for that particular time. So within the called the lifespan of the platelet. However, ticagrelor is basically fast acting. Within 30 minutes is going to be effective, and it just lasted about 12 hours. So that's why you need to take it as a BD dosing. Okay, so then you need to have another dose again. But it is highly potent, and there's an immature called platelets. That's why then you need to inhibit them because of that's ongoing. So what I learned yesterday during one of my research meeting is when a stroke acutely happen, the stroke engine is keep on running, but you can see this is like touch and go only. Yeah, so we need to basically intervene and stop the stroke engine. Okay. Okay, ticagrelor is a drugs that called just immediately called active. So it is not a prodrug, it's active called compound. However, clopidogrel need to be activated via the hepatic pathway. So there's a prodrug that need to be metabolized and become active metabolite. Okay, so this is what we do when we discuss. We had a patient with acute stroke. So hyperacute or acute stroke. You want to basically assess, it must be a stroke. Don't discuss of antiplatelet. Obviously, this one is not our things today. Looking into here, in majority, if not a stroke. So if anxiety, no, aspirin didn't help. Okay, so then you need to give as soon as possible. I'll try to, if we have time, then I'll show to you how fast then we can discuss about the antiplatelet once we basically have an acute stroke patient. Yeah, so it's as soon as possible over here. So we do ABCD2 score or the NIHSS score, then we do the imaging as soon as possible. And ours is with a vascular imaging. Okay, within 24 hours, that's for sure. Okay, so in terms of saying out loud what we are doing, we need to know it is a stroke subtype that you have go through with me just now. You need to know the etiology, whether it's single, it can be intracranial arthro, it can be a non-significant or non-significant ECAT, it can be multiple, it can be diabetes, smoker, it can be carcinoma, and you need to see the patient suitability when you discuss about the antiplatelet treatment. Sometimes the patient is allergies or intolerant to certain drugs. CYP2, C19 called non-functional early status. We do send this test nowadays. Concurrent management, underlying IHD, you plan for cranectomy or atrial fibrillation, hemodynamic condition, whether the BP is too high or too low, other issues, for example, anemia, gastritis, active smoker, high platelet aggregation, uncontrolled diabetes, high platelet aggregation, and the clinical fertility score. Poor condition. Why you want to start the patient on antiplatelet if you know that the HB is already 6 and the patient is ADL dependent. Sorry, kejap. Anak-anak balik rumah. So this is the ABCD2 score. So the ABCD2 score can be further divided to look at the risk of stroke recurrence. Yeah. So age more than 60, BP more than 140/90, clinical speech just now, and the weakness or the speech or weakness, duration of the stroke just now, and the diabetes. Okay, this is the NIHSS score, if you don't know. And like our guidelines, so basically you can look at the American Heart Association guidelines. The DAPT, which is aspirin and clopidogrel, should be initiated as early as possible. It's already been adopted for many years ago. But this is still at the maybe considered, and we need to change for the ticagrelor and aspirin soon. And ours is still at 30 days. Okay. Oops. Yeah. That's it. That is for my other talk during the World Stroke Day. If you can join us. Okay.
Okay, thank you, Dr. Asyraf. Okay, open for question. Anybody can ask question either directly or through the chat.
Okay, Assalamualaikum. Dr. Wan Asyraf, saya Aiman from medical officer from IAUM Medical Center Kuantan,
Yeah,
Pahang.
Aiman. Waalaikumsalam.
Yeah, from emergency. Okay, so I just want to ask you two questions. First question, I mean the sensitivity, is that any difference we use in ED, Canadian for TIA scoring versus ABCD2 score? Which one is more specific and which one is more specific? The second question is that any roles we give the aspirin, is there any difference we give aspirin 300 or 150 mg for TIA patient or stroke patients? Because there is in my dilemma also like with treating patient in acute stroke actually.
Correct. Yeah. So I'm not aware of the Canadian. Can have the Tafiza, the Tanasrina, or the others called elaborate. Yeah, because of I favor ABCD2 score. But mind you, before I forgotten, ABCD2 score is not for discharge planning. The risk is low, but it didn't mean that you can discharge the patient if it were to be low. If it's high, then the risk is high. The Tanasrina, Tafiza, for Canadian score, as Aiman mentioned.
I'm start hearing it. I'm sorry. Maybe
Oh,
Chow can give some input.
Sorry, I'm not aware of the.
Sorry, I'm also not really aware of that rule.
okay.
Actually, it's my first time. I'm
Yeah, Aiman, I will do the homework and then I'll text you. Okay, so but I answer your next question will be aspirin 300 and 150. Okay, so this is about the onset of the drugs. So basically, if you give the never giving the loading dose, then it may take about 7 days before the platelet being inhibited. So give 75, right? So 7 days to 14 days later. So then you say that this is aspirin failure, right? So if you want to get it within 12 hours later, then you give the aspirin loading at 300. Okay? So that's the reason why you load. But if you give 150, yeah, that's not loading. Actually, the dose is 162 for 2 weeks. For 2 weeks. And that's the loading. The 162. Then maintenance in terms of preclinical study is actually more than 30 milligram, but we give 75 or 100. Yeah. Okay. Am I answering your question? So
Yeah.
I just add on a bit. Clopidogrel, you load, then within 3 to 6 hours. If you go with the point trial 600 milligram, then it as fast as 1 hour to 3 hours. Ticagrelor 30 minutes. That's the reason why you load.
Sorry, menyampuk sikit. I didn't get you. So aspirin should be loaded 300, clopidogrel is 600.
So basically, you choose one of it, and what are your strategy? Because sometimes you cannot stabilize the patient. As I showed just now, blood pressure is too high. I usually don't load when the BP is like more than 180, 110. So I then reduce the blood pressure, and the 3 hours window before the clopidogrel called 300 will be effective. I make sure the BP achieve less than 180, 110. This is against the hypertension guideline, I know. But we have vascular imaging. That's why we're a bit different.
Okay.
Okay, thank you, Dr. Y. Asyraf.
Sorry, but if you were to start double antiplatelet, is the dose 300? Let's say.
Yeah, I didn't show the dose. Yeah. So basically, in the trial, they allow in the DAPT aspirin clopidogrel, they allow even the aspirin to be loaded. However, the protocol is basically the Plavix must be loaded. Remember, because of they wanted the effect of the antiplatelet as fast as possible. So clopidogrel is the one that pharmacokinetic, pharmacodynamic faster. It must be loaded, not aspirin alone. So if you give aspirin loaded, then clopidogrel 75 means you're called using the aspirin as called your first onset of platelet inhibition. So you should just load the clopidogrel if they are hopefully not CYP2C19 non-functional allele positive.
Just wanted to add on Dr. Aiman's question just now. So what is in the guideline that I'm aware of is a high risk TIA and mild stroke NIHSS has less than 4, you give double antiplatelet, correct?
Yeah, so basically as call I put in definition just now, when we are talking about the mild stroke, then we already had the 2 groups. So because of the first line, the less than 4, which is up to 3, so 0, 1, 2, 3. So remember, a stroke can still have an NIHSS 0. So NIHSS 0 doesn't mean not a stroke. So basically, obviously that's as mentioned by Dr. Nasrina. However, with the tallies now on board, you can go to NIHSS 5 and below. So less than 6.
Oh, so now is 5 and below, no longer 4.
Correct. So basically, that's the although the current guidelines still mention as maybe or possible. Okay, but the reason why is basically if you look into the study, there's a bit more bleeding event with the ticagrelor.
Okay. All right. So how about those who are not in the high risk? High risk TIA will be 3 and above, correct? So
High risk TIA, correct? Yeah, 4 equal or 4 and more.
How about those in the low risk of TIA, like probably the ABCD2 score is about 1 to 2? Do you still load double antiplatelet or suffice by just giving aspirin 300 milligram alone?
So based on this trial, it's a single agent, not dual antiplatelet. If the ABCD2 score is basically lower, the thing with ABCD2 score, the lower it goes, the likelihood is actually a stroke mimic.
Oh,
Stroke mimic. For example, we're talking about hypertensive emergency. We're talking about hypoglycemia. So they are not really a stroke if the patient is within the low ABCD2 score. So that's the reason why the trial designed something like that. But based on your clinical judgment, if you think the risk is there, but we cannot see, for example, like there's concurrent ischemic heart disease. I think there's a question now. So then, obviously continue with the dual antiplatelet called prescription, not just stroke. We look at the patient holistically.
okay.
Dr. Asyraf, how about the duration? We need to prescribe patient regarding the double antiplatelet.
Correct.
For both agent 3 galok and also the Plavix.
So in the guidelines we put up, so minimum is at 21 days to 90 days. 21 days to 90 days from the stroke onset. That's the usual question. That's in the guideline. We do give longer if there's intervention, for example, acute stenting, not elective stenting. We don't do elective stenting anymore. Acute stenting, so there's stent inside too, here the brain or at the heart. That's longer, 6 months to a year. Then step down to single agent. The reason why is with stroke is a bit odd. The incidence of bleeding, although the common site is still GI actually, not at the brain. Those with stroke, they bleed on dual antiplatelet the longer you put. So that's the downside of dual antiplatelet.
Okay, thank you. Thank you, Dr. Asyraf. Okay, anyone want to ask any question to Dr. Asyraf? If you shy, we can type
I
on
already
the
answered
VT
that.
chat.
Ray, I already
I
answered.
think that is in the
Oh,
chat.
okay. In the chat. Okay.
Can
Okay, before school. Ray, may I know? Okay. Kartik ask question, in cardiovascular infarction, which organ do we treat first? Can we thrombolize for both together? Or PCI thrombectomy? How to decide which one to do first? Thank you, Kartik, for the question. How about Dr. Asyraf for the
Yeah,
question?
so basically, thank you for the hard question. So basically, Kartik, the thing is, I would say, you know, and we all know, is actually depending on the accessibility that you have. So obviously, if the preferred way, if for example, you have a patient, for example, I just tell you based on the current evidence, yeah. So if you have a fresh stroke and a fresh MI, then easy for you. Thrombolize the brain and then try to see whether you can complete the PCI of the heart as soon as possible. Then don't forget to assess back the brain, whether it's actually opening up or not. Yeah, so those are the things that you can do. So that's one of the way. Or basically what you do also, you use a higher dose because of it's a fresh stroke. You know that with MI the dose is 0.5 10 hectoliters. You choose 10 hectoliters called 0.4. That the brain can tolerate that, although there's documentation of higher bleeding incidence. But in this case, rather than having no patient died, then you need to take the risk of salvaging both the heart and the brain. So I would do that. So we published that. You can look into that. Concurrent ST elevation MI and called stroke. So we thrombolize with 0.4 with the clot burden that the patient have, and we didn't PCI the patient because we know that in our setting, accessibility to primary PCI is very much scarce. Yeah. So it's case to case basis, but that's how I do, and you can look into the publication.
So you use direct to place instead for altiplase. And altiplase the dose is a bit complicated kan for MI. Have to have like 3 times of infusion or something like that. So how do you manage the patient? Kind of interesting. So meaning that like for MI, normally we'll give double antiplatelet, then we give anticoagulant after that. So for this, the case that you had, you give tenecteplase, and of course you have to follow the brain protocol because it's obviously giving more harm, correct?
Yeah, so basically what we can do now, we know that, for example, even with tenecteplase, the good thing about tenecteplase now, we know more with all the trials already positive. Tenecteplase stroke trial is actually positive. Is only going to inhibit going to activate the plasmin about 15 minutes to about 45 minutes, 15 to 45 minutes. So the most, kalau the kidney issues, also going up to 90 minutes, maybe you triple it. So there's no fibrin degradation. So then the patient can clog if they want to clog as usual. So that's the good thing about tenecteplase. As compared to alteplase, it's going to have called a fibrinogen depletion for about 6 hours with a surge of plasminogen activator inhibitor 1. That's why there's some small increase of thrombosis suddenly post alteplase. So basically that's the reason why if you see and you attach to us, we are not following the 24-hour CT scan and called antiplatelet. In a high-risk patient like this, in a stenotic intracranial post-stenting or without stenting, PCI, IHD, or called thrombectomy, lower limb, called acute limb ischemia. So we repeat the scan within 12 hours, called after 12 hours. Then we start the antiplatelet loading immediately if there's no contraindication.
Just not I think regarding Kati question also, if patient have both acute stroke and also acute myocardial infarction, usually when patient we give the TPA, we will followed by the anticoagulant for MI especially. That's for this patient. If we have both pathology, that we still give the anticoagulant for this patient.
That's the thing. So you skip the
Immediate.
antiplatelet.
Yeah.
You skip the anticoagulant after the 12 hours in majority of the time. Within the first 24 hours too, nothing. You don't have antiplatelet. You don't have this one. So that's why the best is actually PCI the patient rather than called just lytics for the heart, because you have that 12 hours. You understand me? So basically, no. Yeah.
Okay, thank you, Doctor. Anybody want to ask any question, further question to Dr. Asyraf?
Sorry, Asyraf. You mean you thrombolize the stroke, then you go for PCI, is it?
Yes, correct, yes. That's the preferred way. But not all the time that we have it.
Fiza, has Asyraf answered the question from Ray? May I know what situation clopidogrel is preferred over aspirin for single antiplatelet treatment in stroke?
Maybe I partially answered, then I'll just share. So basically, if you think it's aspirin failure, which actually from literature, the rate is actually almost similar with the CYP2 C19 risk in the Han China population. So that's about 40%. So you think it's aspirin failure, then yeah, you use the clopidogrel. But nowadays, there's an emerging called practice. We also look into the CYP2 C19 non-functional allele. Then we choose whether ticagrelor or with or without chilostazol as our maintenance. That's how we do in our center.
How do you test for that?
We send to the lab. UITM got it. 110 ringgit Malaysia.
How long will it take?
Within 1 week. I think 72 hours dah dapat dah.
I see.
So the criteria candidate to test for that test, a patient that presented with recurrent stroke.
If you want to give clopidogrel, because of clopidogrel,
okay.
yeah. And you want to be cost effective. You're giving it, but it's not functional. With the CYP2 C19 non-functional allele positive, then the clopidogrel is not active. And from our, if you look into the literature, it was discussed about Han Chinese only. There's high risk, which is documented in stroke population. But what we have in UKM now, we do have Indians, Malay, which is also positive. So we need to know what is our population CYP2 C19 profile. We don't have that in the stroke population. We have in orang asli population. I don't know why.
Interesting.
Okay. Any further question for Dr. Asyraf?
Asyraf, I have two questions.
Yeah.
Okay, number one, if a patient comes in with either mild stroke or TIA, you see there is a atrial fibrillation, it's a rate control, and you think that most probably the causative factor for this is embolic stroke. So do you still give aspirin, or aspirin you don't give it at all and you start this patient on anticoagulant therapy?
Yeah, that's a good question and always a question. So basically, the one in terms of literature, always when I share then evidence first, if this is what called as bridging after AF stroke. So, but bear in mind, sometimes you have a patient not really due to AF stroke. They come just by chance due to lacuna stroke, hypertensive related. But then you see the AF there, and this not a transient AF. So we're talking about clear-cut AF. This is like hours of AF, ECG detected, unequivocal. This is AF, and you want to start the secondary prevention for AF. If you want to bridge for certain reason, because of nowadays we start anticoagulant quite fast with the ELAN trial just published. So the called the one that being studied mostly is aspirin as a bridging. Aspirin in the standard condition. However, in our clinical practice, we sometimes don't give aspirin anymore if there's no reason. The only reason why we give antiplatelet, the aspirin, ticagrelor, called clopidogrel still, is because of ischemic heart disease in majority of the time, or peripheral vascular disease. So only in that situation, there's concurrent anticoagulant and antiplatelet.
So is it effective to put aspirin together with the anticoagulant? Would it increase further the risk of bleeding?
Correct. So basically, the current cohort or registry trial shows the effective for brain is not more effective, and the risk of bleeding is higher for brain. Yeah. However, what I can critique in terms of the current publication is they put into the whole series of long-term antiplatelet together with the short term. So basically, maybe if you still discuss about short duration, what we do is for stroke indication with ICATS, for example, if there recurrence despite on anticoagulant, ada AF dah, ada ICATS juga. So what we do is we give at least minimum of 1 month to the 90 days and correct the underlying disease, hyperlipidemia, uncontrolled diabetes together. Then we pull out the antiplatelet to reduce the risk of bleeding. From anecdotal experience, that's effective. Yeah, so to achieve for the brain. But for the others, I don't think so cardiologists will agree for us to stop the antiplatelet. For vascular, yeah, we know that not much of peripheral vascular called intervention being done, but I also don't dare to remove the antiplatelet because of in the arterial pathology, it requires antiplatelet. And yeah, that's the thing, the weakness of anticoagulant in a fast flow called structure, which is the artery, as compared to the venous system or left atrial appendage, which is actually a pathophysiology stasis.
Okay, so to conclude that it is not wrong to load aspirin while waiting for the decision, probably patient want to discuss on the terms and condition of starting anticoagulant, but there should be some vascular imaging and assessment to see whether this patient really need a antiplatelet, correct?
Correct, yeah. So yeah, but the easiest one is actually the cardiac side. So you look into the history of chest pain and also the ECG changes. So if there is, then yeah, those are the population where you have aspirin sustained after the anticoagulant also.
Okay. I have another one more question. It's a bit out of topic. It's about BP management. when you have a patient with stroke, but not the candidate for thrombolysis, so you allow the BP to go more, more or less up to 220 or 120, correct? And you don't lower down the BP because you want to salvage the penumbra area. Whereas for TIA, it is recommended for you to lower down the BP. But we all know that in stroke, I mean, clinically, patient may not exhibit any symptom, but the imaging shows there is an infarction ongoing. So how do we know? Because not all centers has CT perfusion, not all centers has MRI. So how would you suggest in terms of managing it?
Yeah, so basically that's the reason why I changed my title just now from the TIA to stroke. That's just easy. So basically, both are the same actually. TIA and stroke, they are all the same. I personally disagree with the 220-120. And bear in mind the 220-120 is not based on randomized controlled trial. Till date, there's no trial able to decide on the blood pressure level. However, for us in stroke care, we noticed that if you keep the high blood pressure, I learned this from the Moya Moya patient. Moya Moya patient has a very small vessel. So maybe while we answer this, I'll just show to you, this is a fresh case just now. Sambil menjawab tu. Okay. So you can see my joint apps now. You see my screen?
Yeah, we can see, but okay, it popped out.
Okay. So basically, this patient come with the blood pressure, as Dr. Nasrina mentioned just now. Okay, more than 200. Diastolic, I think 110, not to 120 yet. But the BP is high. Not a candidate for thrombolysis. Okay, this is a CT scan plane. And this is 33 years old with right-sided body weakness. Okay. I go CT perfusion first to confuse you all more. So that's why you need to learn about the clinical things. Then the imaging is always a bit difficult if you don't know the history. If you just look at the CT perfusion, right-sided body weakness, that's not left. This is right. This is left. So ipsilateral slow flow. Okay. It's already changed. This is the important part. Okay, I'll bring you to what is happening. So with the high blood pressure just now, this is intracranial vessel. So just cut short because I want to answer the question. Okay. This is a scan fresh in the hospital, which I can assess even though I'm in Brazil, Japan, Hong Kong. Okay, I know I'm in Malaysia. Can you see my screen?
Yep.
Yeah, and you can see the right side just now is basically, which is not relevant clinically at the moment because of its actually a right-sided body weakness. We know it's over here or posterior. Okay, the blood pressure is high, more than 200. And this is a patient with no M1 on the right, continuity over there, and very narrow and small MCA on the left. Okay, and you can see posterior also. Very, very small, although it's not too bad, it's patent. Okay, and this is 33 years old, it should be better. Okay, so what we learned from this patient, you keep the blood pressure at the level that we discussed in the guideline, then good luck, the patient will bleed or the patient will then proceed with a stroke, since we have the physiology imaging nowadays. So so what we do now is basically we usually follows if you look at the MT trial called Enchanted MT trial, Enchanted MT trial recently. So if the vessels is patent like this one, there's no thrombus, so we go something like 140, 160. Okay, and then we maintain over there. The problem is overshooting. So don't overshoot to 130. In that trial says then the outcome is poor. So we don't do that. But remember, the Enchanted MT is an MT trial. So I still mean that there's no trial that able to prove what I'm talking now is actually the way to go. But that's how we did even when I was in training. So I was puzzled. The BP is not 220/120. Why? We reduce the blood pressure. Then my boss answered, the reason for the stroke is actually hypertension. Then why you want to let the hypertension persist? So in this case, with that perfusion just now, although there's a defect over there, you want to salvage the penumbra over there. You know, maybe this is 140, 160 lah. We know that MAP of more than 90 or 80 should be able to salvage the penumbra. That's quite clear. But when we put in clinical trial, it didn't appear with benefit. I think it's because of the rate we reduce the blood pressure is a bit slow in majority of the time.
Oh, okay.
But it's a bit scary if you don't have CTA. It's a bit scary.
Okay. So this only applies if you have the vascular assessment via imaging, correct?
Okay, so my advice is, personally, maybe we need to do our own cohort study. It's actually not 220/120. At least if I don't have a CTA, I'm very comfortable to tell 160, 180. That's it. The diastolic never more than 90.
Okay.
That's how I do if I don't have a CTA. But again, that's not in the guidelines. And that's for no thrombus. Yeah, if there's thrombus, remove the thrombus first if possible. Dia panjang cerita dia dengan anti-hypertension ni. There's a bit different. And the hypertension is a bit difficult because of stroke. As you can see just now, there's a lot of cardioembolic. There's a clot. Large artery disease. There's four ways stroke out. Then lacunes different. So each one of it different how you approach it. The one that I have mentioned is about lacunes, patent vessels, lacunes, and a bit of stenotic vessels.
So basically you are talking about the one that has no obvious thrombus, you control the BP.
In majority.
You can't offer anything much, but if there is thrombus, then you have to follow. But at the point of we do not know, we follow the guideline at the moment lah kan.
If you are stuck, you're not wrong. We follow the guidelines.
Okay.
But but majority of the time, that's what I have seen because of we know some of the patient, for example, renal patient. So then the renal team come. Yeah, that's normal for the blood pressure to be more 180, 190. Yeah, normal. So then the patient call become bedbound, then patient become palliative, right? And then they ask us to arrange for it. I think it's not fair for the stroke team and neuro if they keep on doing that.
Thank you so much.
Okay. I think no further question, right? It's already 12 past, actually 3 minutes past 12. So I would like to thank Dr. Asyraf on behalf of our neurologist Zaidi for spending your time, your knowledge with us today. And for all, I think tunggu sekejap. Wait, we want to snap a picture, right, Ina? Semua
apa tu dengan dia punya askar?
kena askar. Oh, okay. Okay, so I think semua boleh share screen your pictures. It's just for our record lah, for today's CME.
Aiman. Aiman is actually my student.
Okay.
Yeah.
Okay, Nina, boleh kot ambil gambar.
Kejap.
Okay.
Okay. Alright. Okay, everyone ready? Ada yang tak? Can you switch on your video? We can see your face.
Atsushi Yamamoto.
That's Japanese.
Your friend, Nina?
Not sure, but I think
Okay.
center probably.
Okay.
Okay, alright. So 1, 2, 3. Okay, alright. Yeah, we're good. Please, because there will be no more QR code scanning. This is the new rule by the MMC CPD guideline. So please click at the chat. I've already shared the link for you to put your attendance, and I will send it to the person who is in charge to give you CPD points.
Okay.
Okay, thank you very much. Thank you, everyone. Thank you very much for joining. Thank you, Asyraf. Thank you, Hafiza.
Okay, thank you.